this lecture, we're going to be talking about the approach to shortness of breath in the Cambodian child. Whenever you're approaching a new patient, the history is one of the most important things you're going to be doing. So let's first discuss that. In a child with shortness of breath, you first want to assess the overall signs of respiratory illness. Does this child have a fever? Do they have a runny nose, a cough, sore throat? Have they been tugging at their ears? What about sick contacts? Who could this child have gotten this from? Is anyone else at home sick? Do they attend school? Does someone else watch over them during the day who might have an illness? Also, have they traveled anywhere? Maybe if they've gone somewhere far away, you'll be thinking of diseases that you don't have in your own backyard. Next, for children who are having trouble breathing, have they been coughing? Have the parent tell you, what does the cough sound like? Is it barky? Is it dry? Irritated? Are they coughing up phlegm? And are there times of day it's worse? A lot of coughs get worse at night. So is this something that's keeping the child up all night? Or is it something keeping the parents up all night? Next, how severe is this cough? Are they coughing so bad they cough until they vomit? Are they coughing so bad that they're turning blue and becoming cyanotic? And then next, whenever you think about cough, think about aspiration, both as a cause of the cough and as something that happens because they're coughing. So has the parent witnessed any choking episodes? Do they have small pieces of food that the child might have ingested? Or is there a time when the child was unsupervised and the parent suspects they could have gotten a hold of something that they wouldn't ordinarily eat? So when I think about aspiration, I think, was the kid completely healthy and then all of a sudden started having this terrible cough, which makes me think they might have ingested something? Or was this a kid with fever, runny nose, and now has a cough, which all seem to go together with an illness? Next, we'll move on just from the respiratory system and talk about the child's health overall. Is this a healthy kid? Because that makes a big difference on how well the child's going to do. Is he born on time? Does he have good nutrition? Is this a kid who's been in and out of the hospital, or a child who never gets sick? What about other children in the family and the parents? Are they a family who have a lot of respiratory infections? Do the siblings have wheezing every time they get a cold? And then going back to this child, what about their prior respiratory illnesses? Do they tend to get wheezing when they get colds? Do they use inhaled medications usually? Or have they ever been intubated and needed to stay in an intensive care unit? Next, what about the overall status of this illness? How sick is this child? Are they able to eat? Are they eating enough that they're having a normal amount of wet diapers? And what about their sleep? Are they able to sleep? How irritable are they? How tired are they? Last, you want to ask the parents things they might not have brought up because they're only thinking about the difficulty breathing. Is the child having vomiting, diarrhea, or a rash on their skin? This will alert you to other diseases or to other things causing this child's difficulty breathing. Now that your history is complete, let's talk about the physical exam. First, you really just want to look at the child. Especially when children are having difficulty breathing, you want to keep them in their position of comfort and observe them briefly. How does this child look? Are they having retractions, intercostal, subcostal, head bobbing, nasal flaring? And what about the rate? Is it a normal rate for the age of the child? Is the breathing noisy? Even without a stethoscope, do you hear sounds that you wouldn't hear in a healthy child, like grunting or stridor. And then you auscultate. What do you hear? Is air moving throughout the lungs, or is it restricted? Do you hear wheezing, rouse, or rhonchi? So let's go on to discuss what each of these are. Take a look at this child, for example. So when you're just standing there, does this child look sick or not sick? How is the activity overall? So yeah, this child is very sick. They're not interacting. They're very sleepy. They're not doing much of anything besides trying to breathe. You can see the subcostal and intercostal retractions. It's difficult to see with the mask, but my guess is that this child has significant nasal flaring as well. What about this child? So he is a little bit more vigorous than the last child. However, he does have also the subcostal and intercostal retractions and is pale. This is the same child. It's hard to tell, but after oxygen, his color is improved. However, he still has the intercostal and subcostal retractions. So where do you listen to these children? You want to listen medial to the scapular border on the back and 2 to 3 places on each side, trying to cover the whole lung fields. In young children especially, it's important to listen on the sides, in the mid-axillary line. On the front, listen on the mid-clavicular line, 1 to 2 places on both sides. So here's an example. Here's a practitioner listening to that first child in 1 to 2 spots anteriorly on the mid-clavicular line. Now he's listening to the heart. And on the back, same thing, medial to the scapular border, 2 to 3 places on each side, going down the lungs. Then let's talk about the breath sounds you'll hear when you auscultate. First, we're going to talk about wheezing. Here's an example. Wheezing is a high-pitched whistling noise that you hear most at end expiration, and this is caused from the narrowed airways. To elicit this in a child, you may have the child blow out like they're blowing on a birthday candle, and you'll hear it more at end expiration. Some things that cause wheezing are asthma, bronchiolitis, COPD, or foreign bodies. Here's one more listen. Next, we'll move on to rouse. Rouse are a coarse, crackling noise made from the small airways popping open. And this is when you get mucus in the tiny airways collapsing them. So when the child breathes, they pop open. Some causes are pneumonia or congestive heart failure. Another listen. Now we'll move on to rhonchi. are low-pitched, snore-like sounds. This is from air moving in the larger airways, the bronchioles, when there's mucus, so you can hear that air trying to get through those coarse airways. Bronchitis is a common cause of bronchi. Let's take another listen. Next, we'll talk about grunting. So grunting is a guttural noise, and it's made by the child trying to keep an elevated PEEP, an elevated positive end expiratory pressure. This is when the small alveoli want to collapse, but the child is keeping air in the rib cage to try and keep open these airways. Common causes of grunting are cyanotic heart disease and respiratory distress syndrome in infants. Let's take a look at the child we saw earlier and listen to his grunting. Now that unique sound is stridor. It's a high-pitched noise you're really hearing at the level of the throat. It's from air passing a very narrow airway above the lungs, and that can be seen in epiglottitis, if there's a foreign body in the upper airway in the throat, or a tumor or some sort of constriction. This is a very scary sound because there's not much air getting down into the deeper lungs. So one more listen to that. Let's move on to the rest of our organ systems. So obviously you want to take a lot of time listening to the lungs, but it's just as important to look for other causative organ systems to support or refute what you think is going on in the lungs. First, look at the head. Do they have other signs of viral infection? Do they have a runny nose? Is it watery or is it thick mucus? Look in their ears. Do they have signs of otitis media or an inner ear infection? Then look at their mouth, their mucous membranes. Are they moist or dry? That'll help us tell the hydration status. Look and see if there's any swelling in the mouth. Is this what's causing the difficulty breathing? Are there any lesions in the mouth to tell us about an infectious cause, such as a virus, or an infection just in the mouth itself, not in the lungs? Next, listen to the heart. Are there murmurs in the heart? Maybe this is a congenital heart disease, and the problem isn't really just the lungs. What about the rate? Is this rate far too fast for a child of that age? Or is it too slow that makes you think that they're not keeping up with what their body needs? Then the belly. Is the abdomen soft? Is it distended and full of fluid, maybe pressing up on the lungs, keeping them from getting good air? Does the abdomen hurt? Maybe the child's breathing fast because it's in pain. Do you feel any masses or any abnormally large organs? Then finally, the skin. Look at all surfaces of the skin. Look on the hands and feet for cyanosis. Look for mottling, showing poor perfusion of blood to the skin. After you look at the child, think right away, what tools do you want? What can your nurses help you get? Do you want oxygen for the child? Have you already checked a pulse oximetry? Is the child satting 100%? And then you might not need oxygen. Or is this child satting 90% where oxygen could save their life? What about medications? Nebulized albuterol or epinephrine is very helpful in a lot of illnesses, and the nurses could get it for you right away. Does the child need to be suctioned? Do you have a bulb suction to suction the nose to help the child breathe through the nose? Do you need a chest or a neck x-ray? Is that available? And in very sick children, do you have a bag valve mask? Is it hooked to oxygen? Do you need to intubate this child? So right when you're seeing this child, think about those things and ask your nurses to help you ready them. In summary, you can have a very systematic approach to a child with shortness of breath. As always, take your history first. How healthy is this child ordinarily? Tell me about this specific illness, and then look for red flags and how severe this disease is. When you move on to physical exam, remember in children who are having difficulty breathing, let them stay in the position where they are the most comfortable. You don't want to make them more afraid and they're breathing worse. Calmly listen to their lungs, look at their other body systems, and just watch their breathing overall to get in a picture of how sick this child is and what you can do to help them.